Welcome. Thank you for joining us today uh, for our fourth annual Fireside Chat, where we ask the doc. My name is Dr. Shauna Snyder, and I am on the Pheo Alliance Board of Directors, and I'm going to be your moderator for today's webinar. I am here with Dr. Karel Pacak, and I will provide a more proper formal introduction for him later here in just a few minutes. This program is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. A special thanks to Lantheus Progenics for making this webinar possible through an educational grant. I'd like to let you know about a couple of upcoming events before we get started today. So this evening at 4:30 Pacific or 7:30 Eastern, we will hold our final monthly peer support meeting of 2023. So there is still time to register and attend if you would like to join that event. Also, on December 12th, we will present our last educational webinar of the year entitled The Multiple Faces of SDHB Related Paraganglioma at 9 a.m. Pacific or 12 p.m. Eastern. This will feature Dr. Ali Alzarani. Later that day, on December the 12th at 3:30 Pacific or 6:30 Eastern, we invite you to join the Pheo Alliance for our virtual holiday potluck. We will have games, we'll have a cookie contest, and there will be some, pretty swell prizes for the best cookie. So make sure that you are preparing your best cookie recipe. There's some more information on our website about that event and how you enter the cookie contest. So please go to pheopara.org to find out some more information. You will also have to register, so make sure that you're going there. On a special note, also through the end of the year, the Pheo Alliance is conducting its year-end fundraising drive. Your generous donations ensures that we can continue our mission of supporting those with Pheo not only by providing up-to-date information on these tumors, but also important programs like outreach to the newly diagnosed, our monthly peer support meetings, and one-on-one peer support program. Healthcare provider education and outreach, our Centers of Excellence program, and our educational webinar series. So if you're able, please make your donation today by visiting the pheopara.org website. Okay, our disclaimer for today is that the information that we present in this webinar is for educational purposes only and should not substitute the advice of your doctor and or medical team, because they have in-depth knowledge of your medical history and your current situation. All right, on our agenda today, a little bit different than normal, I'm going to introduce our guests, and then we're basically going to launch into questions. We are streaming live, so if you have a question, if you're watching and you have a question, please write them in, and those will sort of be fed to me live. I have a list of questions, but I'll also take any live questions, and we will try to answer all questions that we possibly can today. Dr. Pacak has been great in saying he will stay on as long as possible. All right, so without any further ado, let me introduce Dr. Pacak. Dr. Pacak is an internationally recognized expert in the diagnosis and treatment of pheochromocytoma and paraganglioma, along with other neuroendocrine tumors. Dr. Pacak established the International Symposia on Pheochromocytoma, which was held in 2022, last year, in his hometown of Prague in the Czech Republic. Several of our PPA board members were actually able to attend this symposia, so it was very nice. He is a recipient of numerous awards, including being named the Outstanding Clinical Investigator from the U.S. Endocrine Society in 2022, at which I was actually in attendance. So it was very nice to see him give his speech. Dr. Pacak is the author of more than 520 scientific peer-reviewed articles, 140 book chapters and 6 books, very well renowned in his field. And last but not least, he is actually my doctor. And I can say without hesitation that he cares not only for his personal patients, um, but for all Pheo patients worldwide. He truly has a passion for helping those with these rare tumors, and we are happy he does because he has agreed to join us today and stay as long as we need him to. This is our 4th year doing this. So, welcome to the chat, Dr. Pacak.
So, Shoshana, thank you so much for the introduction. It's really great pleasure and honor to be here today. First of all, I would like to thank not only you, which I did, but also the Pheopara Alliance as well as Progenics, supporting actually this program. And I will be happy, to answer questions from patients, not only, from the US, but also outside of US, if somebody is, connected with us. And as you mentioned, I am available. I reserved the time, for this meeting, and so it's unlimited. So which means that I would like to answer as many questions as possible, because patients, they sometimes have a little bit hard time, to work with to ask questions from physicians, because they are always busy. We all are, of course, busy. But today is a little bit special day, a special seminar. So I will be happy, to help everybody. Of course, I may not sometimes know, the answer. I will be very honest with you if I don't know, but if I know, so I will definitely comment about your question to my best knowledge. So once again, thank you so much. Really great pleasure, to be here, and especially to be connected with patients, even, virtually, but still to be connected. Thank you so much.
Well, let's jump right into it. So, our first question is, can you give us any new research, treatment, guidelines, anything new that maybe has happened since we did this last year that maybe patients need to know about?
Yeah, so this is very interesting question. So I will start maybe with guidelines and then with the treatment. So the guidelines, yes, there are the new guidelines. Especially, that will be profiting for patients with SDH mutation, succinate dehydrogenase mutation. The guidelines related to SDHD, the subunit, the guidelines was the release, I think that was about 3 months. It's in Lancet Diabetes and Endocrinology. This is a very interesting guideline, about the patient with the SDHD, tumors, I mean pheochromocytoma and paraganglioma. I highly recommend it because there are some really interesting, I would say, views, about the biochemistry follow-up, as well as surgical approaches. And what is also interesting, that this guideline includes the approaches to head and neck paragangliomas. Because as you know, that patient with head and neck paragangliomas very often actually carry SDHD mutation. There is also another guideline that related to SDHB patients, so they will be also very happy. The guideline for SDHB, pheochromocytoma, paraganglioma, has been accepted, I think about 2 weeks ago or so. And it will be published, maybe, if we are lucky, that will be published this month. It will be published in Nature Review Endocrinology. And again, so a comprehensive approach to patients with SDHB. I also recommend actually to patients who have SDHB, pheochromocytoma, paraganglioma, to look at those guidelines, because it covers, as I said, not only diagnosis, but also, for example, a surgical procedure, including head and neck paragangliomas, and including also the treatment option, whether, for example, chemotherapy, radiotherapy, as well as the follow-up. I also would like to tell you that we have in process another guideline And if successfully done, everything is, I would say everything was done, everything was already submitted. But of course, you never know what will happen and what will be the outcome. But this is done in collaboration, especially, with the scientists in Europe, that they did, very exceptional job. And if everything goes well, we could maybe see those guidelines related to pediatric patients with pheochromocytoma paraganglioma next year.
Oh,
So those are
oh,
the three new guidelines that will be really very important for patients. And the first guideline, actually, for example, related to pediatric pheochromocytoma paraganglioma. In terms of the new treatment options, yes, there are some new treatment options. As you know, so we had Lutathera and Azedra, which is not definitely new, but I wanted to tell you that Azedra will be closed. Azedra will be closed most likely sometimes in April 2024. So, but we still have a convention MIBG, and if there will be some question about, how Azedra versus convention MIBG, I will be happy to comment about that, but don't worry about that. We still have a convention MIBG, although the approach to this therapy is a little bit limited, but it will be actually around. About the novel treatment options, especially alpha emitters, alpha therapies. And we are preparing here at the NIH new protocol, especially for those patients who are not responding to, for example, MIBG, or they're not responding to Lutathera. So there will be option, to go through alpha emitters and alpha radiotherapy. The alpha radiotherapy is extremely promising, at least, based on some few studies, although the studies are still very limited. But if we succeed, and I think that, NIH will succeed, and it goes through NCI, National Cancer Institute, we will be happy, to put everything together very quickly. And I think that you can see, this protocol to be in place sometimes next year. So it's not far from
great.
actually today. And there is also the new study, at least, at our institution at the NIH, that it using, some monoclonal antibody. It's first in human clinical trial that is focusing on neuroendocrine tumors, including pheochromocytoma paraganglioma. And we think that that could be very also promising clinical trial for patients, especially with metastatic pheochromocytoma paraganglioma. So those are, therapies that at least I am aware of. And there, of course, are, some that they are in the preparation, but still, in the preparation, these ones that I actually mentioned, they already have, the protocol are, in the final stage. I should maybe mention also the therapy, which is using belzutifan. Belzutifan is HIF2 alpha inhibitor, and it's good for patients who have, for example, cluster 1 pheochromocytoma paraganglioma, like, those that is related to Krebs cycle, like SDHX, fumarate hydratase, and some other mutation that can VHL, that can profit, from this treatment. Merck opened the clinical trial. They extended the clinical trial, and will be
Oh,
also open to patients with not only pheochromocytoma paraganglioma, but with the special syndrome, although there are very few patients with this syndrome, that they have also the polycythemia. And we have also already some interesting data. So I think that that would be another option. These tumors, including, of course, the metastatic tumors, and especially also those patients who have, for example, primary tumors and cannot be operated because, the surgery is not feasible in those patients.
okay. Great.
Mhm.
That's very exciting. I think patients who are listening are going to be very excited to know that there are some new things and that we're you know fairly far along. So that's great. Okay, well let's go to our next one. And so some of these first questions are going to be a little bit more about treatment type things. So, where are we on any novel treatments? Do we know about any novel things that are going on? I know we've talked about like the nanoparticles, and I hear things about that. Do we know of anything that's kind of outside the box?
Well, outside the box, some are in the development. I don't think that we have something, very, very new or very something that we can expect, sometime soon. What is, for example, interesting, so are some local radiotherapies, for example, neutron or proton radiotherapy that can be used, especially for patients with head and neck paragangliomas. And for example, proton therapies, there are two articles that are very interesting. They don't have so many patients, but the results are very, very convincing. That the responses of the patients in terms of disease control rate. If I talk about disease control rate, would be the stabilization of the disease, or even the tumors are a little bit smaller, shrinking, so it's approximately between 96 to 100%. So I think that we will see a little bit some movement in the future. That is my personal view. Some surgeons may argue with me, but we will see certain movement from surgical procedures to radiotherapy of head neck paragangliomas in the future. And because, today we have a very good approaches that they are focusing on the tumor. They are very, very precise. So the side effects affecting, surrounding tissue is very small. The problem here with these therapies, however, is that number one, that, for example, we don't have long-term studies, the follow-ups. So which means, usually the follow-ups, in studies, it's up to like 5 years or so. But we need, follow up, for example, for 10 years, 15 years, or sometimes even more, for a longer period of time to see, how the patient may actually do, whether, those tumors
Right.
start growing or not. And number two, of course, patients must realize that they still have a tumor. And we don't have any, I would say, any tools to predict when the tumor will actually start grow, and if yes, when it's going to happen.
Right.
So because of that, some patients, even knowing that the radiotherapy may be very good option, and especially in patients who are to have some comorbidities, or patients that they have some problems to undergo surgical procedure, they still are very afraid having these tumors inside of their body. Here have, for example, head and neck, and they may choose the operative approach. However, the operative approach, especially for example for vagal paragangliomas, and I am pretty sure that we have some patients who went through this operation, and they did pretty well. But based on the new guidelines that we put together, overall, the experts are not very keen, to send patients with vagal paragangliomas for the operation. There are some other
Okay.
ones that I would say that the operation could be fine, but for the vagal paragangliomas, it's a little bit complicated story.
Okay. Okay. Very good. This person is asking about the absorbic acid study. So that's a vitamin C, I believe. And they're asking if there are any clinical trials underway. We get asked about that one a lot.
Yeah, so I am pretty sure because we published a paper, some time ago, I think about 4 or 5 years ago before COVID, and we have some very interesting data. Although, everybody should understand that those data were experimental. So the data were not actually done on patients, or there was no any clinical trial, although the clinical trial could be put together.
Okay.
However, it's still not there. The results with ascorbic acid are not only for pheoparaganglioma experimentally, but for other cancers. in patients who are treated with ascorbic acids are, very promising. However, if you use, for example, ascorbic acid, patients, they have to realize that it's not like to use 1 gram or 2 gram a day, or to go somewhere to the clinic that they will give them 1 or 2 grams IV, 3 times a week. This is absolutely useless. It will not work. You have to get, very high amount of vitamin C, usually approximately 70 grams, so in the infusion.
Wow.
And then think about it. Who will be here in this country, maybe in the Europe or some other countries, or the regions or continent, it can be done. But in the US, you will have a hard time to find, the clinic or facility, medical facility. They will give you 70 grams, and usually that needs to be done at least twice or 3 times a week. Yes, there are some clinical trials with vitamin C and with those doses, in some patients with different cancers. And I would suggest that the patients look at the clinicaltrial.gov, for example, or search, so special websites to find out where, it can be done, and whether they would actually include the patient with pheochromocytoma paraganglioma. I cannot actually promise that the results, the outcomes will be good, because our study was experimental, but I'm optimistic that it could be. If we put together forces in the future, I think that this clinical trial is feasible and could be done at some institution, for example, in this country or outside, and to see, how the patient, especially with metastatic disease, would actually respond to this type of therapy.
Yeah, very interesting. I'm sure a lot of patients are going to be asking you to start that clinical trial.
Well,
Okay, let's go to our next one. Um, are there any changes to the periodic screenings for asymptomatic SDHB genetic disorder procedures? Any changes to the periodic screenings for asymptomatic SDHB genetic disorder screen or procedures? I think what they're asking is, should they be rescreened for their SDHB genetics? I'm not sure exactly. What do you think on this one?
I am not sure if I understand the question, because SDHB and the procedures, maybe whether they, maybe they say they are thinking about, or they would like, to have answer about, that somebody has a SDHB, and then, the follow up, and if there are some changes in the follow up, of the patient with the SDHB. So everything will be in
Okay.
the guidelines that will be, released. But actually, overall, after the operation, by 8 weeks, you have to have, let's say, if somebody has a primary tumor and the tumor is completely removed, you have to have the measurement of plasma metanephrines, no plasma catecholamines, or eventually urinary metanephrines, but we prefer plasma metanephrines. The catecholamines are not actually in the focus anymore. The catecholamines do not need to be measured in any patients, with the pheochromocytoma and paraganglioma. And, then, so follow up, is between 3 and 6 months after the operation. We would always consider or recommend, to have repeated anatomic imaging to find out if the tumor was completely removed. Okay, so sometimes there are exceptions. For example, if the patient had elevated biochemistry, let's say metanephrines, and after operation, 8 weeks after operation, everything is normal, we assume that the tumor was completely removed, and in that case, we could actually skip, the imaging study after 3 months, from the operation. But if we have some doubts, and especially in the patient that they have, the very abnormal pathological findings that are suggestive that the tumor can be problematic, aggressive, growing fast, even, that we feel that the tumor was, let's say, um, entirely removed, we would definitely suggest imaging approximately 3 6 months, 3 to 6 months after the operation. And then it depends, what the patient had, And there is usually certain algorithm that is outlined in the guidelines, but usually I prefer at least 1 year after, for example, the operation, to measure plasma or urinary metanephrines, and then the imaging can be done. It depends. It can be done every year, can be done every 2 years or 3 years. So if the tumor was big, for example, somebody has SDHB 8 centimeter, there is almost, 90% that the patient, or 95% the patient will end up with metastatic disease. I would be very careful, and I would make exception, and I would image patient at least, once a year. It really depends, how the primary tumor presented, and not only genetically, but also in the terms of the size of the tumor, as well as the, for example, biochemistry and location. Everything what is outside the adrenal gland is worse than something which is in the adrenal gland.
Okay. What if it's they have SDHB but they're
Mm.
asymptomatic? What kind of a schedule should they be on, to do their metanephrines or maybe any kind of imaging? What would you say
Yeah,
then?
so is they asymptomatic? So there are two actually sub groups of patient. One, those asymptomatic because they are carriers, and they are asymptomatic and they are only just carriers. They never had pheochromocytoma, paraganglioma. This was published, very nice article by Dr. Amar and co-workers. And this was published in Nature Review Endocrinology, I think 2019, if I am not mistaken, and or 2019 or 2020, and that describe that the patient should have yearly metanephrines, and every 2 3 years they should have an imaging study. Those are the carriers. They don't have any symptom signs, but they would like to make sure that everything is okay, and they have a SDHX mutation, which means X means subunit A, B, C, D. But there are
Mhm.
also patients that they have a mutation, they are asymptomatic, and they have or already had pheochromocytoma paraganglioma. So this is a little bit misleading, asymptomatic, because, for example, they can have, high metanephrine slash catecholamines, but because everything took time before they develop, these higher levels, and the tumors were growing slowly. For example, for 5 years, 7, 10 years, the body adjusted, adapted actually to these high levels of catecholamines. By the way, patients should know that metanephrines do not actually cause any effect in the body. They are good for the biochemistry, for the proof of pheochromocytoma, paraganglioma, but they don't cause any problems. What actually is causing the problems are, catecholamines, so that are, the most important. And the body adjusted to high levels of catecholamines during certain time. We had just now somebody in the clinic today, and the patient, has been with the tumor about 12 years, and he has levels that are 20, 30 times above the upper reference limit, which is extremely high level, and the patient is completely without any symptoms and signs. And the patient, even his blood pressure, his blood pressure is about 107 over 60 or something like that. So
Wow.
does not mean that you don't have a pheochromocytoma paraganglioma, but you have been
Right.
very long time with this tumor, so you adjust it, you adapt it. I will not go into details what the adaptation means. So which means that, even if you had the tumor and you don't have any symptom signs, don't assume that even they did the operation and you are doing very well. Okay, you may not do very
Right.
well, so therefore, you have to have what I said, after the operation, 8 weeks, then three to
Follow
six
up.
months, and then maybe every 1 or 2 years. It depends, very good follow up, including the imaging studies, because you want to make sure that there is nothing in the body that is slowly growing, even if you don't feel anything.
Okay. I think we're going to answer a lot of questions for patients today on that. All right. Now, let's stick with this SDHB for a second. Are there guidelines for monitoring young children who have been found out to have the mutation?
Yes, there are guidelines. First of all, there are the guidelines in the paper of Dr. Amar and co-workers. And as I
Okay.
said, 2019 or 2020 is published. If you put, the go to PubMed or even Google, Yahoo, put the Amar SDHB and the guidelines, the carriers, SDHB carriers guidelines, you
Brings
immediately
them
get
up.
the article. I think it's free of charge. You can, print it and you can get it. I don't think that there will be any problem. If somebody has the problem, send me email. I will be happy to send you the article. So there are guidelines, and they should start, for example, SDHB. For the children, we should start at the age of between 6 and 10. For the SDHD or SDHA or C, we should start between age 10 to 15 if they are carriers. That for the children, and then describe how we should actually do the follow up. For the children that they are only carriers, which means they never had pheochromocytoma, paraganglioma. And those guidelines
Right.
that I told you about, the new guidelines this year, SDHD, SDHB, describing, patients that are actually, or they had the pheochromocytoma paraganglioma, and what should those patients do? And that actually pretty much applies also for the children, although the specific guidelines for children with pheochromocytoma paraganglioma, including SDHX mutations, the guidelines were submitted already. We don't know what's going to happen, whether it would be positively viewed or not, whether it will be published or not. But so those guidelines will be very good because they have a very interesting points, how actually to approach children. So
We'll
you will
be
get,
on the
for the
lookout.
patients, yeah, for the patients and for parents especially, because there are some parents, that most likely asking those questions. Don't worry,
Right.
if everything goes well in a few months, those the guidelines will be, hopefully, I cannot say for sure, but hopefully will be published, and there will be some very useful information, for parents, as well as all the children who would like, for example, to know a little bit more about these tumors, and having a little bit better insight, how to put the things
Yeah.
together. Mhm.
Yeah, and I may have to make sure that we have a couple of these resources out on our PheoPara website so that patients can go and get these articles if they're publicly
Yeah, I
available.
think
So
I
I'll,
think I
I'll
think I
follow
think
up with
that that
that.
would be, yeah, that's, I think it's very good, and maybe we should, I don't know, so this is not the part of the discussion today, but maybe, your website could have something that if the patient walk into your website, they could get the PDF. I don't know if it is allowed or not, I don't know,
We're
but,
going to
it
look
would
into
be,
that.
they will be able, to get it, because some patients unfortunately don't use a computer or may have a limited access, whatever the reason is,
Yeah.
I don't know, but we should actually help patients who cannot afford actually to get, the PDF, format, easily.
Yeah, I think we're gonna make sure that we have those. I'm gonna get on that one. Okay, let's get to our next question. This next question is about life expectancy for patients with metastatic disease. What do we know?
Well, you are giving me very complicated question. Life expectancy
I'm
is
giving you the
very,
hard ones up front.
it's very difficult. I think that at the end of the discussion, I will have only the easy questions. But this question is complicated, and I will tell you what. Because it depends on the age of the patient. Children are doing better than older patients. Patients who are 60 or 70 years old, they have a metastatic disease. They are not doing so well like there's somebody who is younger. It depends also on the genetic background. It depends on the, if the metanephrine slash catacholamines are elevated, where the tumor is sitting, what kind of metastatic lesions they have. So if they have a bone lesions, I call them long-term survivors because they usually do pretty well. Uh, Overall, of course, there are exceptions, but those patients who
Mhm.
have, for example, lesions in organs, I call them short-term survivors, because those lesions are definitely worrisome, especially if they are sitting in the liver or they are sitting in the lung. So it's really a lot of variables, how to put everything together. But and also, as I mentioned, genetics, because the patients
Right.
usually with the mutation like SDHX, so of course they are not doing so well, but there are many exceptions. Although I would say today, with all the measurements, um, very good follow-up surveillance that is very important was published the Australian study in Journal of Clinical Endocrinology Metabolism, I think last year. So if we do very good surveillance follow up, working with these patients, get these tumors early enough, I think the outcomes are pretty well. Okay, so I don't want to
Good.
put the numbers, because
Sure.
it will be complicated, but there are many variables, unfortunately, and we have to
Yeah.
we have to work with those.
Yes. Yes. And that makes a lot of sense. Um, okay. Let's move on to something a little different. Can you share your thoughts about Lanreotide? I'm not sure this person spelled that properly. Treatment for
Yeah, that's
inoperable paraganglioma.
Lanreotide, so I think it's pretty good treatment. We are using it, so it's also under the protocol that is called Lampara. Unfortunately, this protocol will be closed. This is not our decision. No, that Lampara study actually, and all this, I would say, effort and everything started by Dr. Pheo, who is just now in New York. It used to be here at the NIH, and who is actually, the main investigator and put really a lot of effort and wisdom into that clinical trial. But because there are not so many patients, and maybe there might be, some uh, other reasons as well, that protocol will be closed, or maybe it's closed. However, I can tell you honestly, we have some patients on Lanreotide. It's usually given subcutaneously. The amount of Lanreotide, 90 to 120 milligrams. I prefer 120. Some doctors prefer every 4 weeks. I would prefer every 3 weeks, especially those patients, they have for example, more extensive disease or something that is inoperable. And we were able, in some patients, to get really good results, which means, stabilization of the tumors. Do not expect that these tumors um, mm, will respond the way that they would be smaller. They may be a little bit smaller, so that's true, but this is not really happening very often. What is the winning situation, that these tumors will be stabilized, they will not grow, and if they will not grow, this is wonderful. So the
Yeah.
patient, they have to receive it, as I said, every 3 to 4 weeks, so long-term treatment. Whether they can stop, for some time and having holiday, that may, but I don't know if there are some good solid data, but I feel that maybe they can. But I can
Okay.
tell you, those patients where I have under NIH here, and they are receiving Lutathera outside, overall those patients are doing pretty well. So even the
Good.
clinical trial, it will be closed, or it's already closed, I think. So the patients still can get Lanreotide through their, endocrinologist or oncologist, and still can be treated, as long as the insurance company will actually approve using, Lanreotide for ABCD. But usually they
Okay.
do. They are pretty receptive, either for octreotide or Lanreotide to be used if somebody has inoperable metastatic pheoparaganglioma.
Okay. All right. Very good. Okay. This question is about hypoxia and high altitude.
Oh,
And what are your thoughts on whether it can be harmful for all paraganglioma patients, um, or is it only more dangerous for SDH mutation patients or those with vagal paras? So there's several, I guess, you know, this person is afraid to go on vacation where they would be above sea level or they would be flying on an
yeah.
airplane because they're worried about it. What do you think about it?
So I would not be afraid of the airplane, the flights, because it has not proven, and I don't think that that makes, the big difference or something like that. Especially, for shorter flights, if you would do, some, the flights that, are for 15 hours, these are most likely the longest flights, that could be some problem, but I still don't think that there would be, really big problem. But the problem is, the high altitude. This is my personal view, and it was published also by some, especially, one of the review article that came out, I think, in 2003, 2004 from Bora Baisal. One of the first article, although, the first article came 1973, from, the Andes, from the mountains, that, those patients living in high altitude have, the higher incidence of carotid body tumors. So going back, to your question, yes, I think it does make a difference. And again, it's my personal view, even it's not proven, but for those patients who have actually already tumor, so because I'm not sure whether it works, for patients who have the mutation, whether, high altitude, the patient is in a higher altitude will have higher incidence of the tumor with certain mutation compared, to patient that they will have this certain mutation like SDH, succinate dehydrogenase, and living at the sea level. I don't think, it makes difference, because based on the number of patients, and we had a lot of patients, I never, realized or never detected the differences between those that they are at the sea level or high altitude. However, if you have a tumor, I think it makes can make difference, because you already have, the tumor, and you want to go, for example, to spend some time, so in high altitude. Well, if you are living in high altitude, then, so there is a tumor. I'm not absolutely sure if I would recommend, especially for some tumors that are very sensitive for, hypoxia, or maybe sensitive, let's say, like patients that they have SDHX, succinate dehydrogenase, pathogenic variants or mutations, previously called. So I think that that would be the problem. Those that have a HIF2 alpha mutation, I would definitely not suggest, that those patients to be in a high altitude. But this is, small percentage of patients with, so-called HIF2 alpha mutation. Short term, if somebody likes, for example, skiing, I'm pretty sure somebody asked me who likes skiing, going to Colorado, for example, that is up to
Yeah,
4,000, the meters above the sea level. I think this is the highest, so maybe this person is skiing somewhere on the A basin. So I wanted to say yes, it can make a difference, but short term would be permissible, because that is very short term. Although if you spend several times, I mean several days, in high altitude, the consequences in your the blood and everything are sometimes lasting 2 or 3 months. Don't think that you go, after 1 week you're skiing, for example, in Colorado, that everything, will normalize in let's say, few days or 1 week. Definitely not. Okay. So this is the problem that, we have here. And so I don't recommend it. I cannot prove it, so because it's very
right,
difficult and there are no studies at the beginning, this moment. But I feel that this is, what is most likely, could happen, in some patients. So if, let's say, put this way, if my relative would have, for example, SDHX mutation, maybe VHL mutation, this is in question, I am not sure. or HIF2 mutation, I would definitely not recommend them to live in a high altitude or to go there very often. If you go there, once a, half year or 1 year, because of skiing or spend, some time, for whatever the reason is, maybe fine. Okay.
Okay. Okay. All right. Very good. Okay. If I have an SDHB mutation and one or more of my children inherit the gene, how strongly would you recommend moving to a lower elevation? Oh, we may have just answered this. Will it really make a big difference?
Yeah, we
So we
of
may
course,
have.
as I said, we don't know if the carriers, who have SDHB, pathogenic variant slash mutation, will do worse if they will be living in high altitude. Okay,
Right.
for the SDHB, so I did not see any difference in my SDHB cohort, in my, group of patients with SDHB, that there would be, the difference. But I have to, on the other side, I have to say that most of the patients I have, they are not living in high altitude. So it would go, against that. So, but if
Right.
you have already the tumor, this is something that, can make, some difference. But we are waiting, and there are some investigators who are looking at that. I don't want to just disclose certain things, but looking at certain environmental, I would say, factors who may actually affect the incidence of the pheochromocytoma and paraganglioma, and even prevalence in certain area. Nevertheless, if somebody really would like to be on very safe side, because there is still uh, not very good proof, but we cannot rule it out, or we cannot rule it in. So I still would consider that maybe a lower attitude could be better. Okay.
Right.
So,
Right.
and if there would be something that can be done, and it would not pose, major problems, obstacles, why not?
Yeah. Yeah. I guess the old saying, better
And
safe
it's
than sorry.
especially,
Maybe that
yeah,
applies.
and I should also say, that maybe the exception are patients who have a SDHD mutation, because SDHD mutation very often is related to head and neck paragangliomas, and especially, carotid body tumors, because they can have, approximately just now, the new data is showing, up to 70% of patients with carotid body tumors, they can have the SDHX mutation, and most common is SDHD mutation. And this is sensing, this is the carotid body and chemoreceptor sensing actually oxygen. Here I would be
Right.
maybe more careful, because indeed it's found that the patients living in higher altitude, so at least previously had the higher incidence of carotid body paragangliomas.
Okay. All right, very good. So our next couple of questions are about metastatic, and let's see. So this one says, "Can you be metastatic and on watch and wait?
Can you repeat the question? If they would be, can be on
Can
metastatic,
you
and
be?"
you can.
And
Mhm.
then so you've become metastatic, and can
Mhm.
you at the same time be watch and wait? So we're just
Oh yeah,
waiting, we're just watching, but you're
absolutely,
metastatic.
yeah, absolutely. Because some patient with metastatic disease, the tumors are very stable. They are
Okay.
growing either slowly, or some of them they are not growing. So it really
Hmm.
depends where those tumors are located. So
Okay.
definitely, this approach is supported also in the guidelines, especially for patients who have the stable disease, or very slowly growing tumors. And this also this applies for head and neck paragangliomas. They can be definitely watched, carefully, and to have, for example, periodic screening. So I would definitely do it. I don't have any problem with that, because not all the patients with metastatic disease, they have to be treated, especially they have, for example, few tumors growing very slowly. Well, why would you like to treat them? You treat them very soon. Once you treat them too soon, it's never good. If you treat them too late, it's also never good. You have to wait, for, the good period of time, so when, should enter the treatment, because if you start, too soon, then, they may develop resistance, they may develop side effects. You have to stop it. And then later on, if they develop, metastatic disease, I mean, in terms of, for example, new lesions, or, the progression, you may have a little bit hard time, to use, certain um, medication, or even the previously use medication, that, was not the medication that work, for example, properly for the patient. So this is a little bit more complicated issue that it sounds, and it should be discussed together with endo and onco, and other experts, how to put everything together. But not everybody who has a metastatic disease should be immediately treated.
Okay. So if you were metastatic and you metastatic, this one is specific about metastatic pheo treatment, and then they did
Mm.
PRRT, and
Mm.
they're finished with that, they're still metastatic, what would be the next thing after PRRT?
So if they have a PRRT, the question is, they will be always metastatic after PRRT. There is no report practically that after PRRT the tumors disappear. So complete remission is practically non-existing. I think that
Okay.
was something published, but I don't believe it. Or maybe there was one or two tumors metastatic and the patient got, PRRT. Well, it could happen, but usually we don't treat such patients with PRRT. We treat patients with multiple metastatic tumors. They are growing, but they slowly, or they have a, moderate growth rate. And then, so after the PRRT, you have to assess whether these tumors are growing or not. If the tumors are not growing and they are stabilized, I would not definitely use anything else. Okay. I would wait, and the stabilization can be there for 1 year, but it can be there for 5 years, 7 years. So there is no reason, if you find after the PRRT, the doctor will tell you still have a tumors, to be in panic, because you have to ask the doctor, are they growing or are they not growing? If the patient, I mean, if the physician will tell you those tumors are not growing, I would definitely not treat those patients with something else, or I would not add even another cycle of the PRRT. I would just wait, scan them and see, how they are doing.
Okay. What
Okay,
if
so
what if the
stabilization is the
tumors
key.
start growing?
If the tumors start
Then what?
growing, yes, that's another story. So you have several options. One option is to give them another cycle of the PRRT. And
Okay.
sometimes we do it, and we do it also at the NIH. And we have some patients who got, for example, 8 cycles of PRRT, or even, somebody who's getting 9 cycle, which is, very unusual, because before, we were going with the number of 100, I mean, 1000 millicuries. After 1000 millicuries, you can get, side effects, including, maybe secondary cancer or blood, cancer. So, but these days, we actually even are more open towards to use higher doses. So, which means repeated cycle. And it was published, and I think the first papers came from the Dr. Hicks and others from Australia. So they repeated certain PRRT and cycles, and they had, good responses. So I think that that would be definitely okay. If you cannot use the radiotherapy, whatever the reason is, including, for example, um, bone marrow suppression, etc., you can think about some other options. For example, chemotherapy. But if there is bone suppression by, so the radiotherapy, this is a very complicated situation because most chemotherapeutic agents also inhibit the bone marrow function. So you have to be very careful. So we usually give them some time to recover, and the time should be at least about 3-4 months, because there is a data, not many studies, but there are a few studies that the patients that they are treated too soon after radiotherapy with the chemotherapy, that can be detrimental for this patient, because bone marrow suppression is so profound, that the patients actually can end up with eruption of many lesions and new lesions and growth of existing lesions, because you have to understand, if you use the radiotherapy or chemotherapy, so bone marrow suppression means that you are also suppress the immune cells, the generation in immune cells. And immune cells are those cells that are fighting against your cancer. So
Right.
yes, you can have, stabilization of the tumor at the beginning. You can even have, some partial response of the tumor at the beginning, because, for example, radiotherapy destroy the tumor by just radiation. But, so there are also destroy the immune cells. So sooner or later, the patient does not having immune system that would actually help to fight the disease. So if you don't have immune system, like if you would be in the battle and you don't have a soldiers, you fail, and you will be defeated. Okay, so
Right.
which means that finally you will go in the opposite direction. So I call it sometimes like honeymoon period. So you have everything is fine. After those therapies, patients are doing very well. Because chemotherapy started after radiotherapy, maybe so very quickly after radiotherapy. But so this honeymoon period takes maybe few months, and then after that, because the immune cells did not work, the tumor already started growing and needs some time to grow, and before everything erupts, so it can lead to very complicated situation. Therefore, for
Okay.
example, after radiotherapy, if the patient will fail, regular radiotherapy, which we have practically only MIBG, or the Lutathera practically right now, so they can get also called alpha emitters, and alpha emitters are very good because there is no hematologic toxicity. 3 and 4, great hematologic toxicity is not there, and this is
Okay.
minimal, the effect on the bone marrow. Therefore, those patients in the future will be most likely very good candidate for alpha therapy. And the study that was published, I think, in 2019, Dr. Jordanovich, so from Israel, the responses were approximately after failing Lutathera, after failing mTOR inhibitor therapy, the response was approximately about 85%. So it's amazing, amazing response without any side effects. This is what I think it's coming very sometimes very soon, that those patients who fail those therapies, instead to go to chemotherapy that can further suppress bone marrow, they will actually be most likely very good candidate for alpha therapy. And alpha therapy will be also good because the patients can go home practically the same day.
Oh, wow. That
So,
is great. So
so I
that's going to
cannot,
give a lot of,
yeah, I cannot wait,
a lot of hope.
maybe where somebody has alpha therapy. There are some centers they have it, but it's more still, like under certain protocols, and it's not easy, to get it. But, Definitely, the many centers, European centers are very good in radiotherapies. They are very much ahead. India is ahead, and some others, So I think that we will hear more about, this type of therapy for pheoparaganglioma. I would say, pretty soon.
Good. That's great. I think that's going to give a lot of people some hope that there are some things coming down the pike. Okay, this question says, I've had two pheochromocytomas, so now I do not have any adrenals, but I was wondering why I continue to have elevated normetanephrines. Now, they also have neurofibromatosis type 1 and several tumors. Um, and they're wondering, maybe is it those tumors that are causing the elevated catacholamines?
Well, the neurofibromatosis, if you had, the bilateral adrenalectomy, the question is whether you have total bilateral adrenalectomy. If you did not have it and there is some remnant, I doubt, because they would tell you, during the follow-up, from the CT or MRI, that it could cause, there would not be only elevated normetanephrine because neurofibromatosis comes with elevated metanephrine and normetanephrine. So that's number one. It's so that could be, the cause, but I doubt that this is the cause. The second one, if you had the bilateral adrenalectomy, you still can have, metastatic disease. But I'm pretty sure that physicians look at, especially doing, the abdominal scan or abdomen and pelvis to see, whether there is, some lesion that could be sitting, for example, in lymph node. But again, most likely both normetanephrine and metanephrine would be elevated. The exceptions happen, medicine is not, by 100%, accurate in anything because, as I said, exceptions are exceptions. But I think this is what I would expect. The other option is bilateral adrenalectomy. Well, you are maybe on hydrocortisone and you are maybe on florinef. Maybe, I don't know. You should be on both. And if you are
Okay.
not, you may have, some hypotension or some, I would say, period of hypotension, either, during, for example, during the daily activities, or, maybe even, for example, if you are resting or sleeping, so, and this hypotension, of course, would be problematic because increase the activity of sympathetic nervous system. And that scenario would definitely bring, you to abnormal normetanephrine. So that's another
Okay.
option. I would definitely look at that very carefully, how you are treated with hydrocortisone and florinef. What is your blood pressure during the day? Measure blood pressure several times, not only once or twice, but several times, at least, for the period of 2 weeks, and see, whether you have hypotensive periods. And the last one that, so I'm thinking about is, the sleep apnea, or,
Mm,
if somebody is obese and has a sleep apnea, or, and you even don't know maybe about that, you are not aware of that because nobody told you. And but if you have it, you will definitely have, elevated normetanephrine. Okay. So, and we
okay.
see it very often that the patients are after operation, they think that they have a remaining tumor, that they don't have it because they have a just sleep apnea. And sleep apnea is, definitely common, so it's more common than we thought before because we have a good test, to find out about sleep apnea. And the last one maybe also to mention the drugs. Depends, what kind of medication you are taking. And I'm not talking about hydrocortisone, and I'm not talking about florinef, fludrocortisone. I'm talking about some other medication that you may be taking, whatever the reason is, and this medication can cause, elevated normetanephrine is falsely elevated because it's related to drug, but it's not related to the presence of the tumor.
Okay. All right. That's some great information. Um, all right. Let's tick through a few more of these here. Can you explain more about the use of beta blockers and ACE inhibitors, the protocol pre-surgery? This is a two-parter. Also, what approach would you use for a paraganglioma close to the aorta? So
Yeah,
that's really two questions.
so in terms of, the ACE inhibitors, we are not using ACE inhibitor for the preparation of the surgery. If somebody is using it, I don't think that is, the accepted medical practice for patients with pheochromocytoma paraganglioma. Some patients, they may need it because of the blood pressure overall, so, and yes, we have some patients of ACE inhibitors, but, this is something that is not required, for preparation for the surgery. Beta blockers, yes, they are, but they should actually be related or they be taken together with alpha blockers. Because the alpha blockers, should be used first and beta blockers second. So if you are using beta blockers, ask the question or ask your physician why they are giving you beta blockers. Beta blockers are only given if the patient has, for example, alpha blockers first, and then there is still tachycardia, heart rate is, elevated, and you are not dehydrated, so you are well hydrated, so there is no other problem. So then, so of course, and you don't have a hypotension, severe hypotension because taking alpha blocker. Because if you are taking alpha blocker, of course, sometimes if you have it too much, the blood pressure goes up, the heart, is pumping, so it's beating faster because, wants to, to put to put the blood into the body and to counteract the effect of hypotension. Okay, so if this is not, the cause, and you still have a high heart rate, the beta blockers, should be used. Okay, otherwise beta blockers should never be in use as a first treatment, except, one situation. At least, there might be, more, but, the one that, you should know, if you have a tumor sitting in the adrenal gland and is presenting with elevated metanephrine, which comes from epinephrine, but non-metanephrine is normal. So some patients may have actually, hypotension because, they are actually affecting certain type of receptors. We call them the beta 2 receptors. And therefore, there is a vasodilation. Vasodilation means, that the vessels are a little bit like larger. So there are, the blood pressure goes down and the patient has the hypotension. Okay. Plus, and then increase, the heart rate. Plus epinephrine jumps on the receptors on heart. They are called beta 1 receptors, and also increasing heart rate. In that case, and this is one of the very few cases that we use the beta blockers first before we use alpha blockers, and sometimes we use only beta blockers. But this is only for the patients who have usually pheochromocytoma and is producing epinephrine that is actually converted to metanephrine. So the biochemistry will show elevated metanephrine, but the non-metanephrine will be normal. Okay, but usually the levels of metanephrines are pretty high, when something like that happen. Just be aware of that. Otherwise, there is no reason to take beta blockers and not take alpha blockers. Okay, so you have to be very careful, how to assess the situation and everything there.
That was a great explanation. I know that question comes up a lot, even out on the Facebook support group. When do you take alpha versus beta? So we'll make sure we tell people to come
Yeah,
and watch this.
beta has
That was
only,
really
yeah,
good explanation.
yeah.
Yeah, good. Okay, so the other part of that one was how would you approach, or let's see, what approach would you use for a paraganglioma close to the aorta?
Huh. This is, maybe it should go to surgeons, so of
Yeah,
course, if, the surgically removable and, this is not actually, invading, the aorta, definitely, and the tumor is a certain size, because, if the tumor is too small, the surgeon will not operate, most likely, because, everything, when they open, everything is bloody. Even they have a, intraoperative ultrasound and everything, but it's not so easy like you think. So I would definitely, to do the surgical removal of the paraganglioma. And sooner or later, because one starts invading, the large vessels, there is a problem. And so it's pretty difficult, and can, lead to metastatic disease sometimes, in the shorter period of time. So it depends, of course, on the behavior of the tumor cells. Now, when the tumor cannot be removed, so that's another story to follow up the tumor. If the tumor is growing, definitely will need, some type of therapy, whether it will be systemic, local. Local will be problematic in terms of radiation, because if it is close to aorta, may be difficult. Sometimes cryoablation, but it really depends, so there are some specification when it can be used. Maybe not radiofrequency ablation, because if it is close to aorta, that there will be quite problematic in terms of heat. But really, it's not easy to answer it, because I would need to know exactly the position and how close or how far is from the aorta. But the surgical procedure would be something that I would favor, in case that surgeons and experienced surgeons will say that is surgically removable.
Okay. All right. Very good. All right. So, what is the longest that you have watched a patient with a vagal para that was stable and didn't require surgical or radiation intervention?
Well, that's a great question, but I would say, definitely I would say maybe 10 years or so, so maybe even more. You have to understand one thing, that if you take, patients with head and neck paragangliomas, and there are some interesting studies, I think they came from Holland, if I am not mistaken, about the growth of these tumors. They grow approximately overall. If you take head and neck paragangliomas, the growth is in the largest diameter, approximately from about 6 millimeter to 15, 19 millimeters. It depends. Okay, so and but approximately 30 to 40% of patients will not have any growth. So when you find the tumor in the head neck, and just now you will be in panic, because it's 3 or 4 centimeters. So I say, oh my God, it's growing to, is it going to grow? So you still have a 30-40% chance that those tumors will not grow. This is the final size of the tumor. What is the reason why some tumors are not growing? I don't have any idea whatsoever. But I have to say that there is, good percentage of those who will not have the growth, so of those tumors. So therefore, don't be in a hurry when, for example, the doctor will tell you, you have a head and neck paraganglioma. Oh my God, I have to have a surgery. No, you don't have to have surgery. First, you actually measure, the tumor size. Of course, exactly location, genetic, the background, and whether they are hormonally positive or not. Okay. And then, you repeat it approximately about 3-6 months, and to see whether there is a growth or not. If there is no growth, you have a actually option, to just opt for, the long-term follow-up, and to wait and watch, so that would be okay. And but you still have a tumor. But there are some patients, despite that, they will tell, look here, I don't want to have the tumor. I don't want to go every 6 months or 12 months later on, through imaging study. because it's stressful for me. I would like, this tumor to be removed. So the tumors that can be removed, so carotid body tumors usually, so especially, up to certain size, but there are, pretty, that can be pretty well managed. And then jugular tumor or jugular tympanic. Tympanic should be removed, most of them. Operation may not be easy, but can be done. Jugular tumors usually depends, because the operation can be very complicated. But there are some very good experts, that they can operate on these tumors, but it depends on the size. But the good for patient is that these tumors, compared to other tumors, that they have a the slowest growth from all head and neck paragangliomas. Okay, and if there is no chance, for example, operate on this tumor, they can be reached very well with radiotherapy, for example, stereotactic radiotherapy. The results of stereotactic therapy are absolutely beautiful. Okay, 80-90% of these tumors, even a higher number are so are stabilized, and without any growth for 5-10 years. There are some very good results. So vagal paraganglioma, I don't recommend surgery. I am not surgeon. Somebody can criticize, my view. That's fine. But I can tell you honestly, practically most patients with vagal paraganglioma will end up with consequences. The consequences can be very problematic, difficult, and even, some of them will, I would say, recover. They may recover fully, they may recover partially, but the operation is very complicated, difficult, and is very costly. Okay, so we have, for example, radiation, stereotactic radiation, that is working very well. So, and if the patient, tumor is stabilized, why to go, through operation that has extremely high risk, especially, the cranial nerve, inferior cranial nerve palsy. So it's really problematic, for these tumors. But there are some surgeons that are very good, of course, and they operating on these patients. I don't have any, problem with that, because this decision of the patient and the surgeon. But I honestly, if this is happening, that's fine. And I had some patients that were operated for these tumors, and some of they did well, some of they did not so well. I would like to see the data, before I, if I don't see the data from a large group of patients who were operated over, let's say, certain number of years, so it's a little bit complicated. But we had, the first Congress on head and neck paraganglioma in Italy few months ago, and actually experts, and they were very good experts in doing the surgery of head and neck paraganglioma as well as radiation. I can tell you honestly that most of them are actually more and more reluctant, to operate on patients with vagal paragangliomas, because, the radiation, especially stereotactic radiation, and those approaches are working so well these days and can stabilize the tumors for a long period of time. As I said at the beginning of the seminar, we don't have a data, beyond 10 years. But, so there are good data, for long-term data, that these tumors can be stabilized very well. But some tumors must be operated vagal paragangliomas. For example, there is, problematic mass effect. The patient is doing, much worse. You need, the surgery for vagal paraganglioma. So don't take me wrong. So there are some, of course, indications when you have to definitely operate on patient with vagal paraganglioma or do radiation to irradiate these tumors.
Yeah. Okay. Okay. So this person has several surgical procedures getting kind of in the future that they're getting ready to have to do, like a knee replacement and some things like that.
Uh,
They were diagnosed with bilateral pheochromocytoma, so right and left
mm,
adrenal, Um, one of them was removed on the right. That one was removed by robot. The one on the left was left there because they were unsure if they could do both. I think at the same time. So there's two questions that this person wants to know. Is there anything available to see if I have any more pheos, for example, in my bones? So, in other words, did they go metastatic? I think is what they're asking. And then two, I have so many upcoming surgeries. Um, I'm not sure exactly what they're asking me here. Um, but I have to go through that. Could this left adrenal be stable? Okay, so I think sort of they're asking two things. This is what I think they're asking. One, how do I know if I have any more? Which you've sort of talked about that. You'd have to get rescanned. You'd have to redo some
Mm.
plasma metanephrines. Okay, but then the second one is I think could they do these surgeries while they have the remaining pheo in the left adrenal? I think that's what they're
Well,
asking.
it's a little bit complicated. I'm not sure if I understood everything. I know what you said, of course, and but let's say, if you have any remaining Pheo, you most likely will have a positive biochemistry. Okay. And even if the biochemistry will not be positive because the Pheo is very small, that would need to be less than 1 centimeter, usually 6 to 8 millimeters. So the other option would be, to do the imaging study. And the imaging study, especially, good CT, the thin cuts, so that would definitely get, the tumor, and to see, whether there is something. And of course, you can use the functional imaging. That could be also helpful. But I think that CT, very good CT, would discover if there is any tumor. So that's what I would do. I would use, the good biochemistry for metanephrines, and I would use, also good CT, which means, with the very thin cuts, to see, whether, you can get, the small tumor in the adrenal gland. And of course, the bone lesions, you would get them most likely by biochemistry, but because they will be positive on the biochemistry. The biochemistry will be, more elevated, then, would be related to tumor that would be, for example, 6 millimeter, 8 millimeter, that you immediately know that something else is going on, which means that this is not only the tumor that is sitting in the adrenal gland, of course, for example, here in the left adrenal gland, most likely, but sitting somewhere else. So you may have, for example, metastatic disease or another primary, because when you had, bilateral adrenal pheochromocytoma, or pheochromocytoma, because pheochromocytoma is adrenal, so then, so you have genetic disorder, definitely. Okay. Whether, it was discovered or it was not discovered, you have genetic the disorder. Bilaterality, equals, the genetic problem. So you can have other primary, in the body that is causing, for example, elevated biochemistry. Okay, so it's a little bit situation that I don't know if I understood well. It can be a little bit more complicated. I would suggest some good centers, usually tertiary centers, university center, specialized hospitals, to look at you and to do good workup to find out what is going on.
Right. If someone has a tumor and they need to have
Mm.
a surgery for something else, what do we recommend? Like this person's saying they need to have a knee replacement. So what would we recommend if they do have some of these tumors?
Yeah, so well, that's interesting question. So the knee replacement, it's operation that is planned, it's scheduled, is not something which is urgent unless the patient had, for example, some accident or something is going on and has, for example, infection or something else, that's another story, because, we, even despite pheochromocytoma, we call it like, you know, almost like the rule of surgical divergence, which means, so you don't go to pheochromocytoma, you opt, to move out of the pheochromocytoma or go to something which is acute, which is problematic, difficult. And that's it. For example, if somebody needs, for example, cardiac bypass, somebody needs, the surgery because the bowel is obstructed for whatever the reason is, patient has a gunshot, wounds or something like that, fracture that has to be repaired. Of course, nobody will operate on pheochromocytoma first, to fix, gunshot, of course, So that's pretty much clear. However, if you have a knee surgery that is scheduled, I would not go to the knee surgery unless, your physician will actually address the pheochromocytoma. So the first here should be the operation for adrenal pheochromocytoma. And of course, if it is feasible, not all the pheochromocytomas can be operated because, they are so big and, they are, for example, locally aggressive. Locally aggressive means that they go, in the surrounding structures, and it's so difficult, and they are around the vessels, that you would lose, for example, kidney, etc. So it's very complicated, and sometimes surgeons, they don't want to, not that they don't want to do it, but, that can be very complicated, and they may not achieve, radical resection or complete resection. So but if they can, so definitely schedule the pheochromocytoma first, and after, pheochromocytoma is done, which means it's removed successfully, then, the knee surgery should follow, not the way the way around. As I told you, only, that if there are, the situation that, for example, there is, the urgent situation, something acute, that, you don't care about the pheochromocytoma. You still care, but the anesthesiologist must know about that, and that would be completely different. Okay.
Yep, that makes sense. Okay, this question: could Pheo/para, be cyclic, like Cushing's can be? And if so, would this make a difference in testing?
Well, no. The answer is no. Yes, it can be cycling in terms of the release of catecholamines. We know about that because patients, they don't have symptoms and signs every minute, every hour, every day, even every week. So from time to time, they have it, So that would be maybe okay to say that they are so-called spells, and they come in an unpredictable way in most patients, not in all, but in most patients. And they, for example, some patients, they have it, during certain situation, but as I said, most of the patients comes and goes. And it can last 1 minute, 5 minutes, it's up to usually 10, 20 minutes, some patient 1 hour, but it's not a very typical. So that's this group. However, if somebody has a pheochromocytoma, there are metanephrines that we measure, and the metanephrines are released continuously from pheochromocytoma. So if the patient does not have a spells, does not mean that the diagnosis will be missed, because, as I said, every second, every minute, metanephrines are released from the tumor. So if you do the blood draw, blood sampling, when the patient is, in deep sleep, at 2 or 3 o'clock in the morning, doesn't matter, if there is pheochromocytoma, as I said, usually 6-8 millimeter and larger, you can usually, so get, the positive results, and that the patient has the pheochromocytoma. So the cyclic sort of, in terms of how you view it, so because the catecholamines are really released this way, but the metanephrines are, continuously released. So it's a little bit difficult. We usually don't use the term the cyclic, pheochromocytoma / paraganglioma, like, cyclic Cushing, so which is a little bit different term and different scenario.
Okay. Okay. Um, and you may have just answered the question for the next one. And it says, which test to run for biochemically silent paraganglioma? And this person said the 24-hour urines are elevated when having an episode, um, and just slightly elevated when not in an episode. So, what other tests do you recommend? Um, the CT, MRI, and the GA68 dotatate did not pick up on anything. The FDG CT had an uptick near the top part of the colon and in the bone marrow. A couple of abnormal lymph nodes, um, and her doctors cannot seem to figure them out.
Well, this is a little bit complicated because, I have not seen the patient. But, if the biochemical is silent, so we have a little bit problem with nomenclature here. If something is biochemically silent, does not produce catecholamines, so usually, which means, that you cannot measure anything related to catecholamines or metanephrines or so-called 3-methoxytyramine. It would be biochemically silent, pheochromocytoma. And that's, how I view, this tumor. So what you have only, or what you can do only is, to do the imaging studies. First, you can do the anatomic imaging studies, CT, MRI, but they will never tell you anything about whether it's really pheochromocytoma or paraganglioma. They can help you because, uh, for the Huntsville unit, I will not go into that, it's a little bit more complicated, but that's the number of Huntsville units, especially over 30. It can be, let's say 20 is something that is acceptable, but I would say if you want to be, more sure about everything, it's about 30 or higher. But then you have an MRI that you have a so-called bright image on the so-called T2 image, so you can get it, and then you will be a little bit more sure that, that could be pheochromocytoma. But again, if it is pheochromocytoma, you can have, for example, in differential diagnosis that gives you, the same problem like hemorrhage, a metastatic lesion to the adrenal gland, or adrenocortical carcinoma. They all will have, same, higher Huntsville unit, and they will have, of course, the bright T2 bright image. Then, but let's say you have it, and you are more convinced that it can be pheochromocytoma. By the way, if you have a biochemically silent, you cannot have any symptoms and signs. If you have a high blood pressure, if you have some, episodes of sweating, episodes of palpitations, nervousness, anxiety, definitely not related to pheochromocytoma. If something is biochemically silent, how you can have, these problems? Those problems are related to something else. What is something else? I don't know. You can have, for example, anxiety or panic attacks or something, so that is in differential diagnosis, and we will not go into that. So then you go to functional imaging, and you have a so-called specific functional imaging for pheochromocytoma/paraganglioma. And this would be, mainly the dotatate. I think you mentioned dotatate was negative and FDG is positive. Well, the FDG can be positive around the colon. It can be non-specific, can be lymph nodes, can be positive, but who knows, what's going on. Depends on the also size of the lymph nodes. If they're up about 1 to 1.5 centimeter, it's not, sometimes, not always, but sometimes, it's not very, very worrisome. But you cannot do it by FDG. You have to have a CT scan to measure it, properly. So it's a little bit the difficult scenario. So your physician needs to put everything together, whether it's pheochromocytoma or not. And if they are not absolutely sure, they can still do the biopsy. We don't do biopsy regularly, for the pheochromocytoma paraganglioma because it's not something that it should be done, although the paper was published just recently from Sweden that the biopsy is not so danger like we used to think about if the patient is well prepare, and everything is done under certain conditions. But if you have a biochemically silent pheo or paraganglioma, they don't produce anything. So even if you go into the tumor with the needle, you will not have any hypertension. You will not have any problem with the heart rate because they cannot release any catecholamines because there are no catecholamines because they are not producing catecholamines. So only, the option, how to get the diagnosis if they don't want to do the surgery. For example, the tumor is too small, or, something is, problematic, there are some other barriers, to do the surgery. The one option would be here, to do the biopsy.
Yeah. Yeah, that's a bit of a complicated one. It sounds like they're really just not finding anything. This person sort of sounds like they have some symptoms of some sort, but they're just not
But the
finding
symptoms
anything.
cannot
That's
symptoms cannot come up, always
It's biochemically silent. That's
Vagal
true.
silent. That's something else. That must be, something. And I have many patients who are sending me messages, whether they can be evaluated here at the NIH. And we usually don't if they have a biochemically silent, they have a normal biochemistry because they have, something else. And that something else not absolutely clear whether it's related to some medication, it's related, for example, to some anxiety. They may have some unrecognized panic attacks or something, else that can be there. So it's very difficult for these patients because they sometimes, honestly, I tell you, some of my patients, they told me they wish to have a pheo because if they would have a pheochromocytoma and catecholamine producing, they could actually, go through the surgery, remove, pheochromocytoma, they will be fine, so everything is fixed and that's it. So for them, being in limbo, with the diagnosis is sometimes much more complicated than having, pheochromocytoma that can be removed and they can do, or they can live, normal life.
Yeah, it's hard when you feel really bad and you feel sick, but you can't figure out what's going on. That's a tough
Yeah,
place to be
yeah,
in.
yeah, yeah.
Okay, this question is why, after almost 1 year after removing the tumor and one adrenal gland, I still have weakness, dizziness, and heart pain. All of my exams are normal.
So,
What do you think might
so,
be
so
going
the
on?
patient had removal of one gland or two glands.
Removal of the tumor and one adrenal gland.
Well, yeah, I don't know whether the tumor was in the adrenal gland.
I
Most
don't know.
likely.
Most
Okay,
likely.
so the if the patient has, some weakness, tiredness, low energy level, I will do the ACTH test, to see, if there is, the good production of cortisol. So it's very easy test, it can be done on outpatient basis, and really very, very easy test. And the reason is, usually with the unilateral adrenalectomy, which means, that only one adrenal is removed. Usually we don't see it, but who knows what is in the second adrenal gland? Maybe, the second adrenal, the contralateral adrenal gland is not working for whatever the reason is. Maybe, there is some anatomic, problem, defect, something, was there before, who knows, so you never know. So if the patient has, this problem, especially after the adrenalectomy, even it's rare, but may happen, I would definitely do a CTH stem test. So that's number one. And then also some patients, and I don't know how old is the patient, but another problem can be not related to adrenal, not related to pheo. I would look at the thyroid test, thyroid function test, TFTs, if there is, some problem with the thyroid function. And this is not related, but some patients may have it, so this kind of problem. So I would definitely look at that. So these two tests. I would do ACTH test and thyroid function test. If they come up normal, then so that's question: is the patient male or female? Do we need to measure, for example, testosterone levels? Do we need to measure growth hormone? So the depends on what is the age of the patient. So it's a little bit more complicated, and the endocrinologist, whoever is there around the patient, I'm pretty sure that that person will be able, to assist the patient, with several tests and to find out what may be the reason. If the reason is related to some endocrine disorder, there are many other disorders that can cause, tiredness and low energy level, but we are talking about the endocrine. So I'm mentioning, something that I think that is more common than something which is less common, and we don't have a time to talk about what is less common.
Sure. Well, those are good recommendations for this person. I'm sure they're watching. So, okay, if chemo hasn't worked on a pelvis tumor, she's this person. I don't know if it's a he or she, but they've done chemo for 6 months, and they say it's not working. They have a pelvis tumor. Their doctors are recommending to find a clinical trial or the pill, and I'm not going to say this right, cabozantinib.
This is cabozantinib, yeah.
Yep, cabozantinib. That's what they're recommending. Do you have any recommendations, or what do you think about that? Finding a clinical
Mm.
trial or this pill?
Yeah, there was a clinical trial, MD Anderson, I think Dr. Jimenez. I think that the clinical trial was either closed or on hold. So disease control rate in 3 months, approximately 90%. But, in a 12 months, if I remember, was like, between 20 or 30, maximum maybe 40% or something like that. So, well, it's this drug, may have, some definitely good effect, especially at the beginning, whether in long term cannot comment because I have never used this drug and not working, with this drug. I usually suggest, axitinib, patients if they fail on certain type of therapy, for example, CVD, therapy, or, the radiotherapy is problematic and the patients are, progressing, or they have the temozolomide, which is also on my list. But I don't think that, they should not try, definitely not. But, my knowledge, especially my expertise, is limited. However, the data, for short term, as I said, are promising. For long term, I would say are less promising. So it really depends, how to approach it. But my favorite drugs are either CVD, if the patient can get, this combination. Another one is axitinib, and the third one is, or second one is temozolomide, although there is overlap between CVD and temozolomide. I don't have a time, to go through that, and then the third one would be, for example, axitinib, but it's not easy to get axitinib, but it can some patients can get it, so through the insurance, because they usually are offered sunitinib, but sunitinib is a little bit harsh, for patients. So axitinib is somewhat, tolerated better, at least, from the patients that we have. I'm not saying that I'm absolutely correct, but this is, the experience that we have, because, we are closely working on some patient with Dr. Pheo, who actually put, the idea and everything around axitinib together, and who is actually supporting or almost pioneering, this drug in paraganglioma. And I think that he has a pretty interesting, good, and promising data.
Okay, very good. All right, so we are being told that we can have just a couple of more questions.
Yeah, you, because
So
then I will be exhausted.
I know, me too. We've been going at this
Yeah.
for a long
You
time.
you
Okay.
you are in better position because I'm talking a little bit more. So that's just
Yes,
okay.
that's
Just
right.
okay.
That is
You
right.
know, so it's
Um,
I promise patients that we will answer as many as questions as possible. Go
that's
ahead.
right. Um, okay, let's do just a couple of more. Here, I think this is a good one. What is the treatment for a spinal tumor?
What is the treatment for spinal tumor?
Spinal tumor in the spine.
Yeah. Yeah, it depends, where it's located. If it's located next to the spine, it's just regular surgery. If it is related, to the spine, like, it's going into, for example, the vertebral bodies, there are different procedures or approaches. Neurosurgery is one, but it's usually if there is something imminent with the fracture or the vertebrae is collapse, or, there are some, the mass effect, that needs, the neurosurgical procedure. If the tumor is not very big, and the tumor is, smaller, so I think that either radiofrequency ablation or cryoablation, it depends where the tumor is. Sometimes, radiofrequency ablation is fine, but, it's using heat. Cryoablation, it's, the low temperature. So if you go, up, to the area like, the thoracic spine up, and especially C-spine, the cryoablation, may be better. And always needs to be done by very, very good experts, okay? It has to be done by somebody who is very well trained in this procedure or procedures, and which means intervention, usually intervention radiology. There are only very few centers they have, this kind of experience, especially, including pheochromocytoma, paraganglioma, metastatic lesions. Those procedures can be very good, because they usually remove the tumor entirely, usually, and the patient is done, well. There are no complications. A patient usually can go home, if not next day, they in a 3 days or something like that. So of course there are exceptions, but approximately, this is what is happening. Neurosurgical procedure, of course, for the spine, and we had many patients, for neurosurgery. That's completely different situation. Big tumors, something which is pressing on some certain structures and must be done, by neurosurgery. The recovery is much, much, much longer. And then, of course, the tumors, can be also addressed by, the radiation. And, so from the radiation oncologist, who will actually choose what kind of radiation would be too good for the patients. We have definitely very precise radiations today, including, gamma knife, cyber knife, etc. So they are very good. It depends, where is the lesion, whether the lesion is moving or not. So which is important, because cyber knife, can actually measure, very well, the images when something is moving, instead of, gamma knife. So it's really depends where the spinal lesion is positioned, and how it's actually the spinal lesion can also move, with, for example, if the patient is breathing, imagine if somebody is breathing and has thoracic lesion, of course, thoracic spine, will be a little bit, moving, and compare, to other parts of the spine, But the radiation oncologists are very good, they have a lot of good experience from patients with other tumors as well in the spine, so they will definitely come up with good suggestion and good approach, as well as neurosurgeons. Okay.
Okay. All right, there are two here that are really good. I don't know if we can get to both of them. Let's see
We
if
will
we
get
can
both
try
them,
these.
that's
Okay,
fine.
them both, and these will be our last two. But I think these are good ones. Do we have any long-term studies yet done for the long-term effects of high catecholamines?
Yeah, so there are, of course, that's pretty good studies, especially, the studies that came actually from Europe, and some of them came, from the Czech Republic in terms of, the heart, the performance, the function of the heart, as well as, for example, carotid arteries. So there are, those studies, they were published approximately, I would say, 5 to 10 years. And we know that, of course, long-term elevation of catecholamines affecting, the heart, affecting the performance of the heart, as well as, that, carotid arteries. So those studies are actually available, and they can also cause, some ischemic events and everything, because, they have, the effect on the, for example, coronary arteries, vasoconstriction, ischemia, etc. And of course, long-term arrhythmia, so of course, exhausting the heart, so it can be actually problematic for the patients, okay? So because you understand, the heart is pumping 70 to 80 beats per minute, and for some patients pumping, 110, 120. 120 would be on the higher side, so but whether even 110, so it's pretty approximately, 20% more, on daily basis, so for the long term, so of course, the heart, is definitely more exhausted than it would be in somebody that has heart rate 70 to 80%, okay? So
Yeah.
this definitely there. And as I said, the vasoconstriction is also problematic, so, and we have a study that we found that patients with, that they have the elevated catecholamines, the vasoconstriction is the problem. Not absolutely atherosclerosis, that would increase atherosclerosis, so that this is not something what we found, but we found that, the vasoconstriction is definitely problematic, and that can be related to ischemia of the cells, the cardiac cells, and ischemia of the cardiac cells, results of, dysfunction of those cells, the the heart is not functioning fully properly, on the regular, I would say the performance of the heart would be definitely suboptimal.
Okay. I think we're going to get this last question in, and that is, can you explain a bit more the correlation between tumor size and relative risk of metastatic disease? Is
So it
there a
is pretty,
correlation?
yeah, it's pretty well published, So the paper came, I think in 2017, European Journal of Cancer. And so, but there are some other studies, like from Mayo Clinic. There are pretty good studies also. They publish something, and also we publish something, the tumor size, we call it the size matters, and it really does. I will tell you something, in simple way. Everything what is between 8 and 10 centimeter has very high metastatic potential, and whatever is, over 10 centimeter end up with practically in all patients with metastatic disease. Of course, as I said at the beginning, nothing is 100%. There are exceptions, but most patients who end up with metastatic disease have the tumors that are over 10 centimeter. So that's pretty much obvious. So everybody who has, big tumors should have very good follow-up, very good, regular imaging studies, biochemistry and everything, because it's worrisome. If the doctor sometimes tells you, no, you have a rare disease, this is never metastatic, you will be fine. Yes, the tumor was big, we removed the tumor. There is no any invasion in the capsule, invasion, lymph node, lymph vessels, or vascular invasion, so you will be doing fine. Not really. So that's, I hear it from many patients who actually told me, I did not do anything because my physician told me it's benign tumor, so it will not metastasize. So size really matters. I think that size is one of the most problematic risk factor, to develop metastatic disease. And it's my personal view. Many doctors, many experts may not agree with me, but I think that the size is more important than maybe at the present, because we still don't dissect metastatic disease very well, is maybe more important than, for example, genetic background. Okay. So that's my personal view. If somebody has the tumor that is 3 centimeter or maybe 4 centimeter, very good outcome. Okay, very very good outcome. His patients, can be assured more that they will do well. Of course, we have some patients who develop metastatic disease at the tumor 1 centimeter, 2 centimeters. As I said, again, nothing is perfect, but those patients are very rare, or much rarer. That would be, less frequent. That would be the patients, for example, with bigger tumors. The genetic testing, if you have genetic testing, that makes difference in the size in terms of, the size at the beginning. So if you have a patient with so-called sporadic tumors, so you don't have any genetic problem, so the tumors up to 5 centimeters would do most likely well. Okay. So 5 centimeter will be fine. From 5 to 6 centimeter, you start having, higher metastatic potential. And if it is over 10 centimeter plus minus, it's guaranteed that, most of those patients will have, the metastatic pheo paraganglioma, especially paraganglioma. So then you have a SDH mutation, as SDHB, although I would say SDHA is also very problematic, although, some would not agree with me. But I think that this is very problematic mutation. But let's say SDHB, because there are some good studies for SDHB. So if the SDHB is approximately 3.54 centimeter is worrisome. Okay. So once again, what is the sporadic? Everything starts from the size approximately 5 centimeter and up. Okay. If you have a SDHB, everything starts from the size 3.5 to 4 centimeter and up. Okay. So therefore, you have to be very, very careful. What is your, the genetic background? Despite what I said before, the genetic background is, I would like to say, almost like secondary, because I think that the size matters, and it really, in my view and experience, it does. But on the top of the size, you look at, what is their, genetic background. And also you can look at the biochemistry. So those that they have elevated so-called 3-methoxytyramine, but don't worry, United States, unfortunately, nobody measure methoxytyramine. I still don't know why. So if there is elevated methoxytyramine, so this is also contributing to, so higher risk of metastatic metastatic disease. Okay. So, but because we are not, we are measuring at the NIH, but nobody else is measuring. I think nobody. I don't think that anybody is measuring, but I don't know if nobody. So the methoxytyramine, but this is what is about the size of these tumors. Okay, so 10 centimeters, almost definitely between 3 and 5 centimeters, or 3.5 to 5 centimeter. It depends on the genetic background. When
Okay, that's
everything
very helpful.
starts being problematic. Okay.
Yep, very, very helpful. So we are going to close it out today. Thank you so much for your time and the dedication that you have to your patients. And I'm going to say it again. I said at the beginning, you care about patients, whether they're your personal patients or whether they're a patient you've never seen, and that's worldwide. So we tip our hats to you, and we thank you so much for doing these things and for really looking out for patients. We really appreciate it.
Yeah, I would like to thank you so much once again for the invitation. Also, those organizations that are supporting or supported, the seminar. I would like to wish all the patients, to be in good health, to have a good people around them who actually have a good experience, with these tumors. And I would like to wish everybody, very good and pleasant holiday. And if somebody has any questions, any comments, or somebody would like, to contact me, please do so. I only would like to say that I will be on travel beginning next Friday. That will be a little bit longer travel. So if I don't respond, it's not that I did not receive your message, but I will not have most likely the the NIH email. But after I come back, I will respond to you. But if you have something, before I leave, somebody, especially some complicated urgent situation, I will be happy, to do so. So once again, I wish everybody, very happy holiday, all the best, good health. And once again, thank you for having me, for this seminar. It was great.
Excellent, excellent. We also need to thank Mike, who is behind the scenes doing our live streaming. He let us go a little bit long, so we want to thank Mike at Lock Lives Media for letting us do that. The webinars, it should be available in a few days on YouTube and on the website, the Pheopara Alliance website. Don't forget to sign up for our e-news and follow us on social media as well. And then today's special hashtag is hashtag let's talk about nets. All right. So if you forward the video or share anything about the video, try to use that hashtag. And then a couple of other things. Don't forget, we are in our end of year fundraising drive. So you are our reason, for existing. You're the reason that this organization does what it does. You are our most important partners in this fight against Pheopara, and we would really appreciate any of your financial support. It is really vital to our continued success. You can again go to our website, and there's a donate button there. Special thanks again to Lantheus Progenics for making this webinar possible throughout an educational grant. And then thank you to everyone who attended today. We hope you have a great, happy holidays, and please stay healthy.